Good morning, everybody, and welcome to Georgia Heart Grand Rounds. This program is brought to you by Georgia Heart Institute. Any financial relationships of the planners and speakers have been mitigated. If you have a question for the presenter, please wait until the Q&A segment. The evaluation will be shared with you at the end of the program. If you are viewing online, you can submit your questions in the Q&A feature, and we'll read it aloud. Your evaluation, if you're online, will be posted in the chat. And now I'd like to invite Dr. Egelum to introduce our speaker.
All right. Hey, good morning. Once again, thank you for joining us for today's ground round. Excuse me. It gives me great pleasure to introduce Dr. Olga Toleva. As you guys know, she's our interventional cardiologist and lead interventionalist for the Coronary Physiology program here at the Georgia Heart Institute. She's practiced medicine for over 20 years, and she's a well-renowned expert and has extensive experience in teaching, research, and community outreach. She was previously an associate professor at the Emory University School of Medicine and worked at the interventional cardiology department at the St. Joe's Hospital, and was an important member of developing and taking care of patients in the Women's Heart Health Clinic there as well. She's a previous assistant professor of cardiology at the University of Manitoba in Winnipeg, Canada, and an interventional cardiologist at his St. Boniface Hospital in Winnipeg. She earned her medical degree at the Medical Academy in Sofia, Bulgaria, and her master's in public health from the Clinical Effectiveness Program at the Harvard School of Public Health. She also completed her residency in family medicine and internal medicine at the University of British Columbia and a cardiology residency at the University of Alberta and fellowship in interventional cardiology at the University of Alberta as well. Please join me in welcoming Dr. Toleva.
Good morning, everyone. Olga, thanks for the kind introduction. I'm very pleased to see several people here in the room on a rainy day. So without further ado, I'm going to start our presentation. I have the following disclosures. The objective of the talk today is to discuss chest pain and ischemia syndromes in women beyond obstructive coronary artery disease. We are all familiar with coronary artery disease where the arteries are completely blocked and cause angina. But what is more common in women is angina and ischemia with non-obstructive coronary artery disease, also known as INOCA. Also, myocardial infarction without obstructive coronary artery disease, microvascular dysfunction, coronary vasospasm, myocardial bridging, and also spontaneous coronary artery dissection. In this review article that we just published, we discussed the mechanisms of coronary ischemia in women. And as you could see, atherosclerosis and obstructive disease has a place in coronary syndromes in women. However, women are more prone to develop ischemia in non-atherosclerotic setting. Entities like microvascular dysfunction and Takotsubo, spontaneous coronary artery dissection are more commonly seen in women than men. Further to that, there are specific entities that we didn't know much about, like the Takotsubo syndrome, which is predominantly seen in men, which shows normal coronary arteries, however, severely disrupted left ventricular function in the form of an octopus trap. Also, microvascular dysfunction, where the small vessels are not flowing properly despite normal appearing epicardial vessels, as well as spontaneous coronary artery dissection, where 90% of patients are predominantly women. Therefore, research and interest in this field has increased over the past 10 to 15 years. We know that often when we take patients to the catheterization lab, we expect to see stenosis that are more than 70%, which would explain why patients have myocardial infarction or angina. But in the setting of stenosis that is less than 50%, we identify this as non-obstructive coronary artery disease. And despite lack of obstruction, patients could still present with ischemia with non-obstructive coronary artery disease, where we see documented ischemia on a stress test or an EKG, or angina, where there is no troponin elevation or per se ischemia on the nuclear scan. Despite that, the patients have severe symptoms. Therefore, it is important to understand the mechanisms and the reasons why these patients, despite the traditional belief that their arteries appear normal, still have problems very similar to what obstructed patients have. For example, there could be myocardial bridging or epicardial spasm that are not always visible on coronary angiogram and sometimes may need to be provoked. The microscopic vessels are less than 100 microns. Therefore, conventional angiogram is not able to visualize these vessels. So if there is any abnormality in this area, the only way we would know that is by special testing where we could provoke the microcirculation and be able to elicit its dysfunction, including microvascular spasm, impaired relaxation, or sometimes microvascular plugging as a result of microscopic thrombi post-STEMI. Therefore, we need to know how to be able to understand these microcirculation problems and document them and diagnose them for our patients. Prevalence of INOCA and ANOCA is being unknown for many years. First of all, because for many years we called this a syndrome X. We had no way to document it properly or make the diagnosis properly. But we know that 50 to 70% of patients with chest pain have no obstructive coronary artery disease. This is a huge number. And of those patients, 70% are women. Estimated prevalence in the world is between 3 to 4 million in North America. In this large meta-analysis where patients with non-obstructive coronary artery disease were tested for microvascular dysfunction and spasm by the means of invasive and non-invasive testing, the pooled prevalence was 41%. So this again confirms that INOCA and ANOCA are not rare entities. Therefore, when we see someone with unobstructed arteries, we should not reassure them that their arteries are normal, but think about other ways to make the diagnosis and pin it down to what exactly is the mechanism behind it. The combined prevalence of microvascular dysfunction and vasospasm in this particular meta-analysis was, as you could see here, about 23% for CMD alone, and the combination of the two, 19%. It also is important to note that women are more prone to develop microvascular dysfunction. In this meta-analysis, 63% of patients were women. There are documented sex differences, with female having higher risk to develop microvascular dysfunction compared to male. So this is important to know and keep in mind when we manage these patients in our practice. This is a very recent study from Dr. Escanet from Madrid, who took all the patients with stable angina coming into the cath lab and performed coronary function testing to evaluate the presence of microvascular dysfunction or spasm in these patients. And what is interesting here, of all the incoming patients to the cath lab, only 39% had obstructive coronary artery disease, meaning that he did an angiogram, and after that, if you saw a lesion of more than 70%, he went further to perform coronary physiology to assess the significance of these lesions and to identify which ones of those are significant and require stenting or bypass, and which ones are functionally not significant. So it is important to think about coronary physiology when we bring our patients to the cardiac catheterization lab. But what was more interesting, after he did this analysis for the patients who had no obstructive disease, meaning stenosis less than 50%, 45% of the all-comers with angina were actually INOCA patients, meaning no obstruction. So he went further and actually performed coronary function testing by triggering the endothelium-dependent and endothelium-independent pathways, meaning using adenosine provocation and acetylcholine, and identified that spasm is quite prevalent in this population, 54%, as well as microvascular dysfunction, about 22%. So this is probably one of the first studies that shows that the true prevalence of INOCA in patients with stable angina is actually quite high, and even higher than the prevalence of obstructive coronary artery disease. Of course, it's a single center, so it is hard to conclude for the bigger population. And of all these patients, there was about 15% that had no coronary abnormality, meaning that they were reassured and were told this problem is not coming from the arteries or the circulation to your heart, which concludes that it is important for us to go beyond the coronary angiogram because we are able to explain to the patients if there is particular fix or if there is particular medication that could help in their situation. Non-invasive testing plays a major role in the diagnosis of microvascular dysfunction in a way that performing a PET scan where we measure myocardial blood flow reserve in a combination with coronary CTA increases our yield to make an anatomical and functional diagnosis of patients and specifically women. As you know, women have rarely or less calcification than men. Therefore, calcium scoring may miss some obstructive coronary artery disease, and we've certainly seen this in the cath lab with female patients. When we have no access to invasive coronary testing with coronary function testing, PET and CCTA could be good options where we could make the diagnosis. And in speaking to my colleagues yesterday, in our new green tower, we have a new, very modern PET scan, which will allow us to perform this. And not only that, but also evaluation of myocardial bridging by dobutamine stress in PET. So we're very fortunate to have this technology in our center. Another important way of diagnosis of microvascular dysfunction is stress cardiac MRI, which is something that utilizes adenosine in the MRI lab and allow us to perform absolute measurements of flow to the myocardium and myocardial perfusion reserve, which is being linked to making the diagnosis of microvascular dysfunction. These are also very sensitive and good methods for patients who don't have access to coronary invasive testing. So why invasive diagnostic procedure for INOCA and not just non-invasive? As you can see here on this classical picture, when we go to the cath lab, what we see on the surface of the heart are only these big epicardial vessels. But what lays beneath the surface is this network of microcirculation, which remains invisible to the eye. Therefore, of course, myocardial perfusion with MRI and PET are helpful to help us understand how this perfusion works. However, the only thing that we may not be able to evaluate by doing non-invasive testing is the assessment for coronary spasm. And the reason for it is that in the invasive testing in the cardiac catheterization lab, we are able to infuse acetylcholine directly into the big vessels and able to document specifically spasm and how severe it is. Further to that, we also have ways of measuring the microcirculation by thermodilution and Doppler, where we could see how the microcirculation responds to stress and to adenosine. Therefore, invasive testing is more comprehensive than non-invasive testing. And we're fortunate to have a big volume program here in our center, one of the two in Georgia, and I am very privileged to be part of this. Here is a pathway by which we test. I know it appears as a very busy slide, but what I just want to emphasize is that when we go to the cardiac catheterization lab after obtaining a coronary angiogram, which shows normal appearing coronary arteries, we could go further, like Dr. Escanet's study from Madrid, and use a coronary wire, which we normally float into the left anterior descending artery. And by this, we measure coronary flow reserve and resistance in the coronary arteries after infusing adenosine, which gives us an idea of the coronary microvascular dysfunction. If we want to go further and use acetylcholine, we could infuse it directly into the left anterior descending artery. And if we visualize spasm of greater than 90%, we make a diagnosis of coronary vasospasm. Sorry, the circles have shifted a little bit distally. And if we see a myocardial bridge, we can also perform measurements of the functionality of the bridge and decide if it's causing any ischemia and needs further testing or treatments. Here is an example of a patient down here at our hospital, a 41-year-old female with chest pain. Her left heart catheterization in the past showed normal coronary arteries. She was told that she has a myocardial bridge. As you could see here in this particular spot, there is a very subtle milking or squeezing of the artery with every heartbeat during systole, and this is what myocardial bridge appears to be. And at that point, she was told that she would need medical therapy. She was given beta blockers and calcium channel blockers. Unfortunately, she was unable to tolerate them. Further workup included echo with dobutamine, which showed anterior wall ischemia. And further to that, she continued to have significant issues with exertional angina at certain heart rate threshold. She was referred to our program for evaluation of her angina, and this was her diagnostic first step. You could see the wire into the LAD, which will help us measure the microcirculation. Here is her coronary function testing. What we use in our lab is a bolus thermodilution method by the system called CoroFlow or CoroVentis. And this is the screen we obtain when we test our patients. We start with baseline flows when the patient is resting and measure what is the flow in their coronary artery during rest without provocation. And after that, we start adenosine through the IV. And after several minutes of adenosine, the microcirculation dilates. And at that point, we are able to measure the flow and the resistance in the microcirculation to tell us if the microcirculation is functioning normally or it is not responding to the stimuli. In this particular case, the patient had true microvascular dysfunction with coronary flow reserve of 1.2. Anything less than 2.5 on this system is considered abnormal. And she also had very high resistance with IMR of 51. This is resistance in the microcirculation. And the cutoff is greater than 25. So she had coronary microvascular dysfunction. We then went on to perform acetylcholine, and the 100 micrograms dose is the spasm dose, and you could see here in this particular case, severe diffuse spasm along the whole entire LAD. So this patient had two problems so far on top of the myocardial bridge. We then went on to perform provocation of the bridge, and the evaluation of the bridge includes provocation with dobutamine, where we measured the flow with the wire across that bridge during diastole to see if there is residual problem with squeezing of that bridge on top of the artery and not allowing enough blood supply to the anterior wall. And indeed, in her case, she had a positive study with the dobutamine. And the other interesting thing here is that we always do measurement with IVUS to evaluate the actual squeezing function of that bridge. So in this segment here, you will be able to see a halo, and I'll show you, it looks like a black ribbon on top of the artery, and where the ribbon is the bridge. In this particular case, she has it on both sides, and see how the artery contracts during systole and diastole. So this lady had a significant myocardial bridge by dobutamine provocation, and also by morphological measurements. So these studies take a bit longer. However, it is important that all the measurements are performed correctly. And what is important is that myocardial muscle bridge index, which is the thickness of the halo that we see, which is that black ribbon that I showed you, and the length of the bridge to tell us if this bridge, here it is, you could see it now squeezing right at this point. And the other important part is to make sure that there is no atherosclerosis, or if there is, how significant the atherosclerotic burden is in these patients. So what happened to this patient is, after we identified this significant bridge, which was not very impressive on an angiogram, and you have to remember that what we see on angiogram is not always the bridges that are causing problems. Sometimes they could be very subtle, as this one. We also saw that she has severe microvascular dysfunction and also severe coronary spasm. So the first thing we tried to do is to optimize her medications. We tried high doses of beta blockers, combination of beta blocker and diltiazem, and she was unable to tolerate these medications. She was very, very symptomatic. We are fortunate in this center to have a robotic surgeon that is well known across the country to perform robotic unroofing of these bridges. So she was able to go to the operating room in October, and Dr. Guy performed robotic unroofing, minimally invasive, releasing this area, that band that I showed you. And after her surgery, 3 months later, which is about now, she is angina-free with rest and activity. She has been doing really well and off all of these medications, and the only concern right now we have with her is her POTS, for which she's going to see a POTS specialist, and she is using compression stockings and ivabradine to combat these symptoms. So sex differences in CMD have been well described, and this is why the talk today is about women and ischemic syndrome, but also men could have these problems. However, coronary microvascular dysfunction diagnosed by high IMR, which is the resistance in the microcirculation, is more prevalent in male, whereas diagnosed by low CFR is more prevalent in females. And in this analysis from Ontario that we presented a couple of years ago, you could see that women in general are the ones that are prevalent in the endotypes with low coronary flow reserve. And therefore, the initial studies of coronary microvascular dysfunction that were focused on women, like the women ischemia syndrome, were mostly focusing on coronary flow reserve. Why coronary flow reserve? Well, first of all, because it has prognostic significance, and in this meta-analysis where they evaluated not only female, but men and women, more than 5,900 patients were seen. There were also patients who were patients with heart failure, and therefore, we saw in this analysis that 1 in 4 patients with abnormal CFR will die in 3 years. So it has major prognostic significance. Therefore, obtaining this measure and being able to talk to our patients about this prognosis is very important. In our studies here, we not only test patients with angina, but also a lot of patients that the heart failure team refers to us who have had chest pain and also diagnosed problems with heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. As I mentioned, the pivotal study that talked about the prognostic value of coronary flow reserve was the women's ischemia syndrome by Dr. Noel Berry-Mertz. There have been multiple analyses, but the interesting one is the long-term 10-year follow-up in these patients who were all women who had non-obstructive coronary artery disease and underwent coronary function testing and were diagnosed with low CFR or spasm. And what they found in this study that both endothelium-dependent and endothelium-independent dysfunction had poor prognostic sign. However, low CFR was associated with early death and increased cardiovascular adverse events, where spasm was more associated with recurrent symptoms and recurrent angina hospitalizations. So this is also important to bear in mind when you face patients with these particular syndromes. A lot of the times I'm asked, why are we doing these testing when at the end of the day we end up giving them beta blockers, calcium channel blockers, and long-acting nitrates? Well, for many years it has been very challenging to make a randomized trial, and this is a pivotal randomized trial on therapies coming from Glasgow. And what they did was they did coronary function testing, and based on the findings or the endotype, whether it's CMD or spasm, they assign the patients to a specific treatment. For example, microvascular disease responds more to beta blockers, whereas vasospastic angina responds more to calcium channel blockers. Non-cardiac chest pain, they were sent for other investigations. As you could see here, not only the angina improved because it was targeted to the specific endotype, but the quality of life of these patients improved. So this is why it is important to not just blindly throw different medications at them, but rather try to figure out what actually works, because it not only improves their symptoms, but also their prognosis. This is a paper that we just found out is accepted for publication yesterday, and I worked hard on it to summarize different therapies based on specific endotypes that we diagnose, and also how we manage the overlaps. So for example, myocardial bridges respond well to beta blockers and calcium channel blockers that slow down the heart rate. Of course, unroofing, and then therapies that are unlikely to help, and we know that long-acting nitrates actually make reflex tachycardia and bridging symptoms worse. And so on and so forth. For coronary microvascular dysfunction, beta blockers are the first line of therapy, and then second line of therapy are these particular regimens. And then if we have an overlap between the two, what would be likely to work? This table was based on all available randomized trials published to date that will help us tailor therapy. Again, more trials are necessary for us to understand better how to help these patients. And now we're going to switch gears to MINOCA, myocardial infarction with non-obstructive arteries. Again, something that we see a lot in our cath lab. Patients, here is an example, a 65-year-old female coming in with chest pain. She has anterior ST changes looking like Wellenstein and very high troponin. She goes to the cath lab and has this angiogram, which doesn't show any significant obstruction, maybe some myocardial bridging here, but nothing that looks like to explain why did she have such a troponin rise and why did she have myocardial infarction. So what is the problem? Is it atherosclerosis? Is it myocardial bridge? Is it plaque rupture, spasm? Are these normal arteries? We see this all the time, every day in the cath lab. So she was sent home, and then she was brought back in for a coronary function testing. And this is what we found for her. 1 month later, we performed microvascular testing, and as you could see here, is very interesting. In her case, her coronary flow reserve is normal, but the resistance, the microvascular resistance, is very high. When we see this, this is something that we commonly see post-STEMI, and most likely is due to microvascular obstruction. So then I went on to perform OCT, which is an intracoronary imaging, and I was able to see that this woman actually indeed had atherosclerosis with layered plaque and healed erosion. So this we cannot see on an angiogram. Therefore, we cannot reassure our patients that there's nothing wrong with them, because in this particular case, this woman had early atherosclerosis with active plaque that ruptured and maybe transiently occluded the artery with a clot that eventually dissolved with our medical therapy. And the only clue we had for this, of course, was the high troponin, but also this elevated index of microvascular resistance. Therefore, coronary function testing is very helpful in MINOCA. So what is MINOCA? Same as what INOCA is, but in a setting of acute myocardial infarction, so unobstructed arteries and troponin elevation. This is another entity of great interest in the community because Minoka, again, is very common in women, more common in women than men, and often presents as acute myocardial infarction. We could see new ischemic changes. We could see wall motion abnormalities on echocardiogram. And we have angiograms similar to what I showed you without any stenosis that is more than 50%. And of course, we have to look to alternative diagnosis. This is a simple schema of what we need to walk through in our minds when we are working up these patients. And things that we need to exclude are what we call Minoka mimickers, and that includes Takotsubo syndrome, non-ischemic cardiomyopathy, and myocarditis, which often could give you normal arteries, but the troponin elevation is not due to ischemia, but due to inflammation. Therefore, cardiac MRI is very important. Coronary function testing has an important role in the diagnosis of Minoka because it helps us understand if there is microvascular dysfunction or spasm, and imaging is also very important, intravascular imaging, to give us understanding of the intimate details of the vessel that may explain why this patient had a myocardial infarction. As I said, Minoka is more common in women. In this particular sub-analysis of registries, 1/3 of the ACS in women was due to an angiogram that showed non-obstructive coronary artery disease. Therefore, always think about it when they come to the lab and the arteries appear normal. There has been a lot of development, and a study coming out of New York called the HARP study, led by Dr. Harmony Reynolds, shed a big insights as to what are the mechanisms by which women have Minoka. And what it showed that 43% of females with Minoka who underwent intracoronary imaging had some type of atherosclerotic plaque disruption. So coronary atherosclerosis is not an uncommon reason for why these things happen. Therefore, intracoronary imaging with high-resolution systems, not like the low-resolution IVUS that I showed you, but an OCT or a high-definition IVUS is what will help us understand the intimate mechanisms. So things that are very typical for women are plaque erosion, or sometimes intraplaque hemorrhage, which could cause these type of microthrombi and provoke acute coronary syndrome. This algorithm was published based on the knowledge from the HARP study, and what is important of it is once we ruled out obstructive coronary artery disease, we have to look for subtle things in the coronaries like emboli or thrombus or spontaneous coronary artery dissection. And the most important conclusion of this study is that cardiac MRI is very importantly done in the acute settings. As you could see here, there is a high sensitivity to depict some abnormalities like myocardial edema or early ischemic insult to the myocardium in the first 3 days, and that reduces significantly if it's done delayed after 12 days. So access to inpatient early cardiac MRI helps us determine the diagnosis. Finally, intravascular imaging, as I showed, or coronary function testing helps us identify other reasons for the problem. So we're going to talk about SCAD because it's something that's very common in women, and we see some of it. Once thought to be rare, now we see more of it because we are more capable of actually recognizing its subtle changes. What it is a narrowing of the lumen of the coronary artery, which is caused by intramural hematoma. So what that is basically the intima of the vessel gets disrupted and blood from the lumen starts flowing into a false lumen that compresses the lumen of the artery and causes close to complete occlusion, like here, or 100% occlusion that will induce myocardial infarction. SCAD could present as a non-STEMI, STEMI, shock, and even ventricular fibrillation. So it's something that we always think about if we see a young woman under 50 years old. if there is no major risk factors for atherosclerosis. And it's very often associated with fibromuscular dysplasia, which are changes into the blood vessel wall, as well as connective tissue disease like Ehlers-Danlos, systemic inflammatory vasculitis, and also in young women who had recent intensive exercise or emotional triggers like stressful situations and grief. Here's an example of a 49-year-old woman who was getting ready to go to a church party and was preparing some food in a crock pot. She lifted the crock pot, started having chest pain. As you could see, inferior ST elevation. This was one of my first cases I've done. And you could see in this spot here, the LAD is dissected, but there's still flow in it, but there is significant narrowing in this segment. And there is something spidery looking here, which is her circumflex artery, which is completely dissected, is causing the inferior ST elevation. So she came into the cath lab at that point because she still had ongoing chest pain and angina. I performed intravascular imaging, and you could see here the false lumen around the true lumen, and you see how the true lumen is compressed by the intramural hematoma that's coming to cause complete obstruction of the vessel. In her particular case, I performed stenting, and this is the final result of the spidery-looking OM. And these are the three types of SCAD that we see that have been described based on angiographic appearance. So remember, SCAD diagnosis can only be made based on what we see on an angiogram. We cannot just do it clinically because we saw a young woman in the emergency room and she was upset. We really need to take them to the cath lab. And coronary CTA not often depicts distal SCAD, so therefore invasive coronary angiogram is the only way we could see these subtle changes like this OM here that I showed you. So what about PCI for SCAD? So this was a case that I did almost 10 years ago, and at the time we tried to open and try to stent, but since then we realized that first of all, 90% of SCAD heals spontaneously. So if there is no ST elevation, ongoing ischemia, and the chest pain has settled and the vessel has normal flow, like the LAD I showed you, it's perfectly fine to leave it alone. But if the vessel is occluded, like the OM I showed, we need to do something. And one of the things that we learned over time, over the past 3 years, is that some of the CTO PCI techniques actually help us evacuate the hematoma and release and free the lumen again to restore its entirety. So we published this as first case reports. This was actually one of the first papers we published with Stefan together a few years ago. And what we found is that if we take a wire, and as you see here, there is a little similar looking spidery OM, and if we knuckle that wire and push it and restore the connection between the false and the true lumen, we could actually treat SCAD successfully. So see how big this vessel became once we did what we call STAR technique, or it's standing for subintimal tracking and antegrade reentry. So what actually happens is the true lumen is being compressed by the intramural hematoma, and by using a microcatheter and a wire, we were able to push against that flap and eventually get back into the true lumen. So these techniques, CTO operators are very familiar with, but I think us as just regular operators when we deal with the STEMI is important to be able to be comfortable with because they're life-saving and help us open the vessel without needing to stent it. Here is another case. 58-year-old woman, again here in this center, ST elevation, anterior, and you could see that the artery disappears somewhere here in that mid-segment. So at this point, what is this? Is this a thrombus? Is it SCAD, plaque rupture, spasm? She was discharged home because we were not able to open that vessel. It was the way it looked. And a year later, she came back for coronary function testing. This artery has completely restored its integrity. And when I did functional testing with acetylcholine, you could see that she had severe spasm, and the artery looks very similar to what it looked when she had the STEMI. So the most likely reason what we were seeing at her original presentation was severe coronary vasospasm. She had no atherosclerosis in her vessels. So this is very important that we think about these particular etiologies when we see someone with acute presentation like this. So coronary spasm is something that could cause myocardial infarction and is more prevalent in Asians who are at increased risk of spasm, almost threefold. Smoking is a big risk factor for it, so this patient was a smoker. And malignant coronary vasospasm, although rare, could occur and could even cause sudden cardiac death. Therefore, it is important to think about it and test for it. So to conclude about myocardial infarction with unobstructed arteries, it is very important that all patients who present with MINOCA undergo the diagnostic algorithm that I showed you and also cardiac MRI in the acute setting because it identifies difference between ischemic insult or inflammatory insult. The recommended management is based on what we see on intravascular imaging if there is atherosclerosis, or even after coronary function testing if we see spasm or microvascular dysfunction. Therefore, we need to use this comprehensive tool set that we have here and perform all the necessary tests to find an explanation for the troponin elevation and chest pain rather than reassuring our patients. And in the last few slides, I just want to introduce a new program that we started here at Georgia Heart, and it's called the TRAIL program, standing for the Treatment of Residual or Refractory Angina and Ischemia to Improve Life. What the idea was to encompass the two ends of a normal curve. So most patients that come in with angina are patients who have coronary artery disease and obstructive arteries. But some of them are patients that have very severe disease, like CTOs, or previously told that there's no options for them to be open. And our TRAIL program will be able to do an outreach to these patients. And again, we have a vast expertise here with multiple CTO operators that could help our patients. And on my side, the invisible side, microvascular dysfunction and spasm, patients that were told that their arteries are normal and there's nothing wrong with them, but despite that, they suffer and they continue to have angina. So with this, our patients will have access to care because we have the expertise and we have the ability to then follow them through in our clinic and through procedures that we do, whether it's coronary function testing for the non-obstructive patients or CTO, PCI, and finally do proper therapy and follow them through. As part of the Angina TRAIL program, we now have Lauren, who is going to help us identify these patients and also promote the program, assist us with clinical care by starting database and keeping track of the clinical outcomes. So if you have a patient that needs coronary function testing because you're concerned about INOCA or MINOCA, please reach out to her so that way we could see her, we could see these patients in our clinic. The same for CTO, PCI, or severe coronary artery disease, post-CABG, or after multiple stents where they've been told there's no options for them. And finally, two new programs within the angina or refractory angina realm. We're working on EECP program, which stands for Enhanced External Contrapulsation, where patients who cannot tolerate anti-anginals could get benefit, and these are basically blood pressure cuffs that inflate during systole, during diastole to help the blood flow to the heart, and it's been FDA approved for refractory angina and also for heart failure and YHA class 3. So a lot of patients that cannot make it to the cardiac rehab because they're quite debilitated. This will be their bridge to come back to activity. And very soon, in the next couple of months, will be activated as a site for the coronary sinus reducer implantation, which is a big stent that we implant in the coronary sinus and helps with microvascular angina and also refractory angina. Therefore, we'll have alternative options beyond medical therapy. And of course, don't forget, we have excellent surgeons here that offer robotic unroofing, which now we have several patients that have undergone with great success and complete relief of symptoms. So to conclude, INOCA, MINOCA, and SCAD are more prevalent in women. Don't forget, men also have problems like this, so it's not necessary to only focus on the women, but in our program, we see a lot of male patients with the same problems. Coronary microvascular dysfunction and MINOCA are associated with increased risk of cardiac events and mortality. Therefore, we have to take them very seriously. Vasospasm overall has a better prognosis, but is associated with more frequent admissions to the hospital and presentations to the emergency room. Normal coronary angiogram does not rule out ischemic heart disease. Therefore, we need to evaluate for microvascular dysfunction, spasm, and myocardial bridging. We have to have high index of suspicion on angiogram to rule out SCAD or thrombosis in ACS patients, especially in young women and in pregnancy or peripartum. MINOCA requires the same investigations as ANOCA with coronary function testing and after intravascular imaging. Intravascular imaging is very important, and we are committed here in our cath lab to do that 100% for all our patients when there is uncertainty about the etiology of their coronary syndrome. And finally, guidelines recommend testing with cardiac MRI and cardiac function testing for MINOCA, so think about it early while they're still in the hospital. Myocardial bridges could cause ischemia, and novel therapies like robotic unroofing, as I showed you today, can be extremely helpful in some patients who cannot tolerate therapies. And with this, I'm going to open for discussion. Thank you.
Thank you so much, Dr. Toleva. Excellent. Does anybody have any questions? Please raise your hand and I'll bring the microphone to you.
Thank you, Dr. Toleva. I have a question about the myocardial bridge unroofing. One, I know the unroofing improves symptoms significantly. One, is there any mortality benefit? I know the overall mortality rates of myocardial bridge is quite low, but are there any mortality benefits? And my second question is, what is the patient selection like for the myocardial bridge unroofing? Because if a patient really doesn't want to take medications, for instance, is that an option for them? Or there are certain criteria where they have to be refractory, they have to have maybe like refractory symptoms and not respond to medications before they can go that route?
Great question. So the first question about mortality benefit, as I said, there are not that many randomized trials in this population, both CMD and myocardial bridging, specifically treatments. There's case series, and there is really no evidence. This is basically a symptomatic treatment that helps patients. We are discussing with Dr. Guy to probably publish the series we have, but we still have not that many in our practice. Stanford has bigger case number that they have done on roofing, but their surgeon does sternotomy. So we don't know the answer about mortality benefit particularly. So it's a symptomatic treatment and it's emerging treatment. We only do it after we've exhausted all the venues of therapy. As I showed you, myocardial bridging often coexists with coronary vasospasm or microvascular dysfunction, as an example in this case here. A recent study from Canada also showed that about 85% of patients with myocardial bridge have coexistent endothelial dysfunction or coronary spasm. So before we rush to surgery, we are absolutely making sure that we treat vasospasm to a maximum tolerated therapy, but we first make a coronary function testing diagnosis of what exactly their endotypes are. and if they have microvascular dysfunction, treat that first. As far as who are the bridges, as I showed you in my presentation, we need to prove hemodynamic significance. There are morphological criteria for it, which is the IVAS criteria, and there are coronary physiology criteria, which is a diastolic FFR or RFR under dobutamine of less than 0.76. So I would not send someone for unroofing unless I have done the full coronary function testing, unless I've exhausted all the venues, unless I've treated the spasm if it's present, microvascular disease, because it's aggressive therapy and it's not something that is a first-line therapy.
That was great, Olga. I really thought that was one of the best presentations I've seen in a long time. So kudos to girl power. So to caveat onto the unroofing, as a surgeon, years past we didn't really have physiological studies to prove that this unroofing was actually going to make a difference in someone's life, and for the vast majority of people, it didn't. It really didn't. And so you're taking someone for a risk of rupturing into the RV. Which is real. When you start to unroof the coronary artery, if you get off even a millimeter, you're in the RV, then you have a whole nother ball of wax where then you're doing a coronary revascularization to the distal LAD, and it's just a big hot mess. So we don't take it lightly because these are not the easiest surgeries. First, second, these people bleed. So before we start trotting off to any surgery, we have to make certain that physiologically this is the right thing to do. In the past, it hasn't shown that. And then you have patients who are not satisfied and calling your office nonstop for the next 2 years. And we all know what that's like. So now with what we're doing here, it makes sense. I think this is what us surgeons have been waiting for a long time. And that holds true across the board, because now, although we can angiographically see that there's an abnormality, it doesn't necessarily mean that it's a physiological problem. And a lot of the revascularizations that we've done in the past, which was just a stamp, do this, it didn't work, and we saw failures of people post-operatively. So what we're doing here makes sense to us surgeons, and that's why we're developing these programs for just exclusively bypassing what we need to bypass and leaving the other things alone. So I want to say kudos to us, for you guys, for paving the way forward in the future and thinking like we've been thinking for a while, that not every single hammer is meant to hit every nail. So I wanted to congratulate you on all your success, and again tell you that what a fantastic presentation.
Thank you, Karen. I truly appreciate the collaboration and the synergistic effect that we have together. Most places I've worked before, the surgeons were completely reluctant to do any bridges for the same reasons. And thoughtful selection of these patients with the knowledge of what's underneath the bridge is very important. As I showed today, what we see on an angiogram as a bridge is not always the ones that cause problems. And in this case, it was barely visible, but was physiologically very severe. And therefore, we have created the rule for us as a team, cardiac team, to perform coronary function testing on all the patients that come with a bridge and angina and have requested consultation for unroofing. So we don't let anyone just go for the procedure. And sometimes we even do 2 different tests. I would do the dobutamine stress, non-invasive like an echo, and now we're gonna have the PET, which is gonna be an amazing thing to have, and then invasive, so I could do the IVAS as well. Thanks again.
Excellent. Yeah, really thank you for that wonderful presentation. If there's another question, I had a quick question I wanted to ask. Is there a correlation, so when we do these PET studies and we get the myocardial blood flow reserve, is there a correlation between MBFR and the CFR you get during the invasive cath procedure?
So there has been multiple studies that have correlated myocardial blood flow reserve by PET with coronary flow reserve by the Doppler technique. Unfortunately, the Doppler wire has been under design and has not been available for more than 3 years on the market. It's made by Volcano, but we have a promise that it will be available in the next 2 years. There is another technique called continuous thermodilution, which utilizes the coroventus wire with a microcatheter, and that is something that also is being correlated. There has been concern about the measurements of CFR with the bolus thermodilution. However, for practicality, this is the only invasive tool that we have. And often, if I have some concerns, I would do a cardiac PET and I would do invasive testing to just have additional information if I am concerned that what I'm getting in the lab is not correlating to what the symptoms of the patient is, or vice versa. But the true gold standard correlation is with the Doppler wire. Yeah.
Any other questions? Any questions online? The other thing I'll
Online.
ask would be, so I know there's a lot of things that's been postulated as to why these entities are more prevalent in women versus men, with a hormonal, et cetera. What do you think is the main pathophysiology behind it? Why is it more prevalent in women than, say, men?
So this is a very good question, and there is a lot of research being done on this. One of the explanations is that men earlier in their life develop obstructive atherosclerosis than women. Therefore, we diagnose them early with obstructive disease. Women biologically develop more diffuse atherosclerosis, so even when they have the atherosclerotic risk factors, they're more diffuse, and the arteries on the angiogram, when there's diffuse disease, appear normal. However, when we do intravascular imaging, we identify this is not the case, and they have plaque burden. So that's why in the current era, we are encouraged to do intravascular imaging when we perform these tests, so we don't reassure our patients and tell them you have no normal coronary arteries, because they appear normal, but when we actually look inside, they are quite abnormal.
One last question from me. So with regard to, you mentioned with MINOCA and how perhaps we should be more aggressive in evaluating these patients. I mean, I think certainly we have a lot of these patients who come into the hospital that clearly have myocardial infarction. We send them to cath, and oftentimes we're, well, cath's clean, and we sort of like, okay, we're done, there's nothing to do. From an inpatient perspective, what should we be doing from that perspective, and what would you recommend as we go forward and see patients in the hospital today, tomorrow, or whatever?
Well, I don't want to get in trouble with the MRI department, but as I showed you in the HARP study, the protocol mandated inpatient MRI, and we have seen that many times where we thought someone had, troponin elevation. Why? Even last week, there was a young woman that came. She was peripartum. And when we did the MRI, we saw an LED territory infarction. And vice versa. In some other cases, we've seen MINOCA mimickers, like with the influenza and other viral illnesses. We would identify pericarditis or perimyocarditis. And the prognosis and treatments are completely opposite and completely different. So if we could get our hands on cardiac MRI, especially in very high levels of troponin, again, for us as interventional cardiologists, intracoronary imaging is of utmost importance, specifically OCT. As you saw in the case I presented, there was a plaque erosion with a layered plaque that a month later had healed, but there were subtle findings to suggest that that's what we were dealing with in first place, and this patient would have qualified for dual antiplatelet therapy and being treated as acute coronary syndrome.
All right, well, thanks everyone for coming out. We appreciate you being here, and thanks again for an excellent lecture there. Appreciate it.